Hello, guys. Welcome to my channel. Today, we are going to start our series of cardiology. Cardiology is the major subject and major system that AMC tests in the medicine section. So, I would be covering the important and most high yield topics from cardiology or the AMC MCQ test. So I'm going to start our series with the most important and confusing topics for all of these students. That is ECG. There are some certain diagnostic ECG strips that you have to learn. So I would be sharing that, and I would be helping you to understand the ECG and classical ECG patterns that AMC loves to test. That is the ST elevation, MI, and atrial fibrillation, ventricular tachycardia, SVT, atrial flutter, and heart blocks. So these are some of the most important ECG strips that you have to know. But before that, we are going to start with the basics. So first of all, we are going to start what the waves tell you about the in ECG. So first of all, we have P wave. So P wave is actually the atrial, actually signify the atrial contraction. So SA node fires and it leads to the atrial contraction, and P wave signifies this. So there are certain pathologies that are associated with P waves. Absent P wave. So, in certain disorders, you would find that the P wave is absent on the ECG, and this is a classical sign you have to look for, especially in the cases of atrial fibrillation. So, if there is the absent P wave and the rhythm is irregular pulse, so you would you would diagnose it as atrial fibrillation because there is chaotic atrial firing. So, P wave would be absent, and there would be irregular rhythm. In atrial flutter, the P waves appear as the sawtooth, and then we have tall P wave. Tall P wave are actually seen in P pulmonale. P pulmonale is actually the right atrial enlargement, or which leads to the right atrial heart failure due to the pulmonary hypertension, and which is caused by the COPD specifically. So P pulmonale is denoted by the tall P waves. Then we have the P mitral, which is the notched or bifid type of P wave, just like that. The tall P wave would be like that. So it signifies the P pulmonale. On the other hand, we have the P mitral. P mitral is actually the notched and bifid kind of P wave, and it signifies the left atrial enlargement, which is seen in mitral stenosis. So, right atrial enlargement, we would see tall P wave, that is P pulmonale, and in left atrial enlargement, we would see P mitral. Now, coming towards another segment, that is PR interval on ECG. So PR interval is actually the signal pause that occurs at the AB node. So the atria can finish emptying, and it is normally 120 to 200 milliseconds. So the pathologies associated with PR interval are that if the PR interval is more than 200 milliseconds, that is seen in the first degree block. So first degree heart block, there is the prolonged PR interval of more than 200 milliseconds. Then we have the second degree heart block, and in second degree heart block, we have two kinds: Mobitz type 1 and Mobitz type 2. So if the PR gradually lengthens, it keeps on lengthening until the QRS drops. So it is the Mobitz type 1, that is Wenke-Beck phenomena. It is also termed as Wenke-Beck. And if the PR is constant and QRS randomly drops, it is the Mobitz type 2. So as you can see in these ECGs, the first degree heart block, there is just the prolongation of PR interval, no dropping of the QRS complex. Then we have the Mobitz type 1. The PR is gradually keep on increasing until the QRS drops. Here the QRS is dropped, and after the constant prolongation of the PR interval. Then we have the PR is constant. It is prolonged, but it is constant until the QRS drops. Then we have third degree block. In third degree heart block, the PR and QRS occur independently. That means the atria and ventricle are beating independently. So as you can see, here is the PR interval and here is the QRS, but here are the PR interval but no QRS, and then occurs the QRS complex. So they are occurring independently. And third degree heart block usually occurs due to the Lyme disease, in the cases of Lyme disease, congenital lupus, and diphtheria. We also have the short PR interval, and short PR interval is usually seen along with the delta wave. And this classical picture is seen in Wolff Parkinson White syndrome, where where there is an extra pathway which bypasses the AV node. So there would be the short PR interval and delta wave would occur. I would be sharing, and I would be showing all the ECG strips, showing all these Wolff Parkinson White syndrome heart blocks, and everything I am covering in this video. And with the basics, I would be sharing the ECG strips and examples of these disorders in next video. Then we have the QRS complex. QRS complex is very important. It is actually the signal. It is actually the ventricular when the ventricles contract. So signal reaches his Purkinje fiber and the ventricles contract. So QRS complex signifies the ventricular contraction. So normal QRS is actually less than 100 milliseconds. And if we see the wide QRS complex, it means that the signal is taking time, and it is signal is taking slow abnormal pathway. So wide QRS complex means this. So pathologies associated with wide QRS complex are very important, and these occur mostly in the question seen in the AMC. So if you see the wide QRS complex, so we have wide QRS complex, narrow QRS complex. So if you see wide QRS complex and there is a fast rhythm, we are going to it would be ventricular tachycardia. That means the arrhythmia is arising from the ventricles. So wide QRS complex would be when it is in the ventricles. So narrow QRS complex plus fast rhythm, it means that it is coming from the above. It is coming from the above of the ventricles, and it is usually the SVT. So we can differentiate between ventricular tachycardia and SVT because both of them have the fast rhythm. But the ventricular tachycardia have wide QRS complex, and you would be able to differentiate between the two if you keep that in mind, that the ventricular tachycardia is wide QRS plus fast rhythm. On the other hand, we have SVT, which is fast rhythm and narrow QRS complex, because it is not coming from the ventricles but from the above of the ventricles. Then we have the left bundle branch block and right bundle branch block. These are also they also have the wide QRS complex. So left bundle branch block means the left ventricle's highway is broken, and right bundle branch block means the right ventricle highway is broken, and we would see the axis deviation in these two. Then we have the pathological Q wave. It is the deep and wide, and it is usually seen from the scar from the old MI. That if you see the pathological Q waves, that means that the patient has a history of MI. Now we have a very and most important segment of the ECG, that is the ST segment, and it is actually the isoelectric line. If you see here, this is actually the isoelectric line. This is the P wave. This is Q. And this is the P wave, and this is QRS, and this is the T wave. So ST segment is actually this, and it is the isoelectric line. So in the ST elevation, we actually see this line that is getting elevated or depressed. This is P, and this is Q, R, S, and T. So this is the PR interval, and this is the QRS complex, and this is the ST segment. Now, ST segment is actually the isoelectric line, and deviation up or down. It means if it is deviating up or down, it means the heart muscle is starving of oxygen. So pathology is associated with ST elevation, and you have to keep this in mind. And all of these points are very important. If you see the ST elevation or depression in lead 2, 3, and AVF, it means the MI is from the inferior part, and it is having the blood supply from right coronary artery. So the affected artery in case of 2, 3 and AVF leads would be right coronary artery, and the part of the heart that is affected is inferior. Lead V1 to V2, lead V1 to V4 are actually the anterior leads, and V1 to V2 is anteroseptal, and V3 to V4 is anteroapical, and anterior part of the heart is actually supplied by the LAD. So lead 1 to V4 are the anterior leads, and LED is the supplier of this part. Lead V5, V6, 1, and AVL. These are the lateral. These are from the lateral side of the heart, and it is supplied by the LCX. So if you see the ST elevation or depression in these leads, it means the lateral heart is the lateral MI, and the affected artery is left circumflex. Lead V1 to V3 with tall R wave is seen in the post MI. Is seen in the posterior MI. Now we have ST depression or T inversion, and the troponins are increased, and patient is having a chest pain. That is the non-ST elevation MI. And if there is diffuse ST elevation and PR is depressed, we are going to signify it as the pericarditis, especially if the patient has a history of flu or any other preceding illness and with the chest pain. So we can see the ECG and diagnose him as a pericarditis. Now we have the T wave. T wave signifies that the ventricles are electrically resetting themselves so they can fire again in the next beat. So pathologies associated with T wave are the tall, peaked, tented T waves like this. These are seen in the hyperkalemia, and in hyperkalemia, the abnormality starts with the tall peaked tented waves, and later on they are converted into the sinusoidal kind of wave, and then they can turn into the ventricular fibrillation if the patient is having severe hyperkalemia. Hyperacute and huge T waves are seen in the MI in the cases of MI, and this is the very first sign. T inversion is seen in the ischemia or recent MI. Flattened T wave is seen in the hypokalemia. Now we have the QT interval. QT interval is the total ventricular time, the total work that is done from the ventricle from the ventricle is done from Q to up to the T. So if it is long, it means that ventricle is taking too long to reset, and extra beat can fire upon the unfinished beat. So this is the long QT interval is this that the extra beat can fire upon the unfinished beat, and this is very dangerous, and it is usually seen in the torsades de pointes, in which there is long QT interval, and it is the polymorphic ventricular tachycardia, in which the same lead the waves are not having the same morphology but different morphology in the same lead in case in the ECG. So long QT interval and polymorphic ventricular tachycardia is associated with the torsades de pointes, and drug. It is due to certain causes like drugs. Certain drugs can predispose a patient to torsades. That are the antipsychotics, macrolides, methadone, and ondansetron. And as electrolyte imbalance like hypokalemia, hypomagnesemia, and hypocalcemia. There is also a very important thing, and the students find it very difficult, really difficult to memorize it. So I would be making it easier for you how to learn the ECG axis. So first of all, when you see the ECG, you have to look that the ECG is having the normal axis. So how can you see that? Look for it in the leads 1 and AVF. When you are seeing the ECG, looking for the ECG axis, You have to look for it in the we lead 1 and AVF. So both leads are positive, that is, both leads are thumbs up, and the both of these leads are positive, that would be normal axis. If if both leads are in the opposing direction, lead 1 and AVF are in opposing direction, that means the lead 1 is positive and AVF is negative, that means they are away from each other, or you can say they left each other, or they are opposing each other. An example is that the both thumbs are left each other, so that is in seen in the left axis deviation. And if both leads are towards each other, that is both leads in lead 1 is negative and AVF is positive, so both leads are towards each other or facing each other, that is the right axis deviation. You can learn it by this method. So let me repeat it once again. If both leads, as you see, both leads are thumbs up, it means the normal axis. And if they left each other or they are opposing each other, that's the left axis deviation. And if these are towards each other, facing towards each other, that is seen in the right axis deviation. Let me tell you the classification of tachyarrhythmias. Tachyarrhythmias are actually the wide QRS complex, fall into the category of wide QRS complex and narrow QRS complex. So wide QRS complex, that means the source of arrhythmia lies in the ventricle. So it can be monomorphic or polymorphic. Monomorphic means there is the same morphology in the same lead, and it is seen in the ventricular tachycardia. Polymorphic ventricular tachycardia and the wide QRS is seen in the torsades and ventricular fibrillation. So it is polymorphic. That means there is a difference in the morphology of waves in the same lead. Now we have the narrow QRS complex. Narrow QRS complex, that the arrhythmia is coming up from the above ventricle, from above the ventricle. So it can be irregular or regular. Irregular is the most famous, that is atrial fibrillation or multifocal atrial flutter. Regular narrow QRS complex is the SVT, and SVT, in under the heading of SVT, we have number of arrhythmias, that are sinus tachycardia, atrial flutter, AVNRT, AVRT, atrial arrhythmia, atrial tachyarrhythmia, or junctional tachyarrhythmia. So you have to keep this classification in your mind so that the tachyarrhythmias can become easier for you. So that's it for this part. I would be sharing the examples of certain ECG and the certain diagnosis in the next video. So keep watching my channel, and please like the video and share among your colleagues. Subscribe the channel. Thank you.